Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for doctors working in rural and remote Australia. Today we are looking at the issues of drug reactions under anaesthesia. Modern anaesthesia is very safe, not only the drugs used, but the training by anaesthetists to prevent and treat unexpected complications. Today we are talking to anaesthetist Dr Paul Sadleir. He is one of 4 anaesthetists at the WA Anaesthetic Drug Reaction Clinic at Sir Charles Gairdner Hospital, the state centre where patients are seen to investigate cases of suspected perioperative anaphylaxis and have future anaesthetics planned. Joining Paul Sadleir is Peter Platt and Russell Clarke. So Paul, what does anaphylaxis look like for someone who has been anaesthetised?
Quite different to how it looks in community members, because usually under anaesthesia you're asleep. Most of the signs that people present with in the community, usually they'll express the symptoms that they're suffering, but of course they can't do that under anaesthesia. The other thing is that anaesthesia will induce unconsciousness and often a respiratory arrest, which is intended, and so a lot of the initial signs are hidden. We're also looking after people who are often unwell and having a surgical procedure because they're unwell, and so that can obscure the situation and mask what's going on. So often it's very difficult to distinguish an anaphylactic reaction to just the normal course of anaesthesia and surgery, and part of our job is distinguishing those. But the most common presentations are hypotension and tachycardia. It's a multi-system disorder, so it will involve, in about half of the cases, some change in airway compliance or a development of a wheeze or some respiratory signs. And of course the most obvious thing is when they develop skin changes or a rash, but often that's delayed, and often after an unstable patient's been stabilised, sort of subsequent to the reaction, that will become apparent, so it may not be all that helpful.
Which drugs cause anaphylaxis under anaesthesia?
Any drug can potentially cause anaphylaxis. Common ones that we see in Western Australia are really muscle relaxants and antibiotics, and from year to year they kind of change as to which is the most common, but they're usually about the same. And we usually see in Western Australia about 20 cases of each of those. By far and away the most common muscle relaxant allergy that we see is to rocuronium, and that has certainly increased in proportion in my time in the clinic. Prior to that, succinylmethonium was very common, but with its reduced use, so has its incidence declined. With the antibiotics, by far and away the most common is cefazolin, and that would reflect its use. We do see other penicillins represented, such as flucloxacillin and amoxicillin, but they are very much the minority. The next most common drug that we see causing anaphylaxis is probably chlorhexidine. The chlorhexidine allergies that we see are really when they breach the skin surface, such as when central lines are coated with chlorhexidine or when chlorhexidine is put into a wound. And that's stayed pretty stagnant in the last kind of decade in Western Australia. Well, the one that's really increasing in incidence is Sugamidex. That's probably about the same in terms of incidence per year as chlorhexidine at the moment. And we've seen both people having allergic reactions to the Sugamidex alone and also to the complex of Sugamidex with either rocuronium or vecuronium. And then after that there's a smattering of other types of drugs that either we administer or the surgeons do. They would include things like gelafusin, Kenacort steroid depots, patent blue dyes. That's about it from the top of my head. One drug type that we don't see represented very much is latex. In the sort of 10 years that I've been involved and the 10 years prior to that I audited, we've never seen a latex allergy in the operative theatre in Western Australia, and that probably reflects how much the latex products are now washed and how little free latex is in the air. But that's probably the common drugs that we see causing allergies.
How do you determine what caused the reaction, or even if an allergic reaction occurred?
Have I got an anaphylactic reaction going on here, or at least is this just part of the anaesthetic process? Because most of the signs of anaphylaxis could be due to the anaesthetic or an intercurrent problem that the patient has. Okay. The common signs that we see are a fall in blood pressure, hypotension. Hypotension can be caused by your anaesthetic or basically the patient being sick. Tachycardia, is common, is very common. So if you've had an otherwise uneventful induction of anaesthesia in a healthy patient and they get profoundly hypotensive, that is unresponsive to your normal vasopressor, and it is associated with tachycardia, you should be starting to think we've got anaphylaxis here. Now, you might also have noticed that airway pressures are going up. All right, the ventilator's starting to alarm. There's something not quite right here. And then you look under the drapes and they've got this florid erythema or an urticarial rash under the drapes. So it's a multi-system condition. In isolation, bronchospasm can be due to something else, hypotension, tachycardia, they can all be due to something else. But that constellation suggests that this is an anaphylaxis. Now, the other thing about that is that, what have I just given? If I've just given propofol, fentanyl, and midazolam, it's very unlikely we're dealing with anaphylaxis here, because those drugs just don't, or very rarely, cause anaphylaxis. But if I've given rocuronium or I've given a cephalosporin antibiotic, then we've got to be thinking. Every time I give those drugs, I think, I'll just keep an eye on things, just to make sure we're not having an anaphylaxis here. So what drug you give is extremely important. The first part of that question, how do you determine what caused the reaction? Well, I think probably we'll talk about that maybe after we've discussed management of towards the end. I think the next step is management. How we investigate the patient comes a bit later on.
Well, the other very helpful thing to determine if there has been an allergic reaction is if you've got a blood sample that you put in a clotted tube for a tryptase. Not all laboratories will do that. I think most samples in Western Australia are sent to one lab on ice. But if you can take a blood sample at the time of the reaction or in the sort of first 1 to 4 hours of the reaction, that's very helpful for us in determining whether mast cells have degranulated and are implicated in the reaction.
So in terms of managing anaphylaxis, I think one of the main priorities in an anaesthetised patient is to secure the airway. Volume is something that's incredibly important. Patients having severe anaphylactic events often require very high volumes of fluid, and that has been quoted up to 50 mils per kilogram of fluid. We would recommend a crystalloids given. We would also recommend pretty aggressive adrenaline therapy. Adrenaline is a very useful drug in stabilising the mast cell and treating bronchospasm, and also has some advantages with treating hypotension. The dosing schedule that I would use would be 20 micrograms intravenously, doubled minutely to effect, although the avenue would really be dependent on the clinician. And if there's any doubt, an intramuscular approach to giving adrenaline is something that is very safe and well recognised. The other thing to consider is the cardiovascular features of anaphylaxis really represent distributive shock, and so drugs to cause vasoconstriction and treat the shock should also be considered. They would really be dependent on what's available to the clinician, but some options available would be aramine, phenylephrine, or even vasopressin.
When I think about anaphylaxis, especially for some reason intraoperative anaphylaxis, it's kind of like an empty heart syndrome. That's the way I think of it. So with the distributive shock, the main reason why you have hypotension is because there's very little blood coming back to the heart, particularly if someone's intubated and ventilated, even more impedance to return of blood to the heart. So sometimes I think if you give adrenaline, although it might increase contractility and cause some peripheral vasoconstriction, it's not actually going to bring any of that blood back to the heart. And that's why giving volume is so important. And that's something that everyone will have. It doesn't matter where you are treating these patients, you'll have volume. And really the question is when to stop giving volume. And as Russell said, it seems crazy, but giving 4 or 5 litres of fluid over 20-30 minutes is not necessarily contraindicated in these patients.
We are talking about the higher grades of anaphylaxis, whereas many of our patients get better very rapidly just on the first or second dose of a small amount of adrenaline. A large majority of our patients get over their anaphylaxis actually very quickly. And in fact, we have shown that continuing surgery doesn't actually cause any problems in the outcome of these patients. So if you've had a minor anaphylactic reaction, you treat it adequately, it's quite okay to continue and finish off the surgery. I think maybe there has this been felt that you should stop surgery if you've had anaphylaxis, but we have shown that not to be so.
I think we've also really focused on the cardiovascular problems with anaphylaxis. There are other considerations. Bronchospasm is something that isn't always seen, but it is quite a common sign that we see with anaphylaxis under anaesthesia. Adrenaline will certainly help, but you'd also consider some of the other bronchodilating agents that would be available to you. I guess the other problem that gets talked about a lot is airway obstruction and airway swelling. It certainly is a feature of many anaphylactic events, but we haven't seen too many cases in our clinic where that has been a threat to life. There have been a handful, but it's not a common presentation. The main presentations under anaesthesia really are from the respiratory system and the cardiovascular system.
The way we grade anaphylaxis currently is that we give it a 4-point grading, and the most severe grade, grade 4, is when patients need advanced life support, so chest compressions, or when they become pulseless and the response to them becoming pulseless. One step back from that is a grade 3 reaction, which is a frightening, life-threatening reaction. And in those patients, the grade 3 patients, only half of them need to go to intensive care afterwards. In the other half, surgery is either abandoned or it continues, again probably about a 50-50 split, and after the surgery and anaesthesia, half of the patients in total are extubated.
A mention of the fact that anaphylaxis in the community, particularly in patients who have asthma, can be lethal, because it's a very different situation to be in the operating theatre, where you have somebody who is looking after you who is very competent at managing the airway, and very often these patients have an endotracheal tube in place. Whereas out in the community, if you have anaphylaxis, you're on a train going from A to B, there is nobody there to manage your airway. So the airway is the principal cause of death in community anaphylaxis, whereas it is much less of a problem in the operating theatre, because we have the skills and the drugs and the tools to be able to manage that aspect of anaphylaxis much more efficiently.
If I was managing, a case of anaphylaxis under anaesthesia in a rural, remote area, the main thing is that we know that for the majority of cases, the duration of the severe reaction is not usually any longer than 20 to 40 minutes. There are occasional cases that are longer than that, but really you just have to hold your nerve and keep the blood flowing for 20 minutes, and then when the histamine has dissipated, a lot of the hemodynamic reactions will resolve. There will still be ongoing symptoms for hours or over days, but they won't be life-threatening.
To sort of extend on that, Paul, as you guys well know, I looked at all the cases over, I think it was about a 10-year period that we have had, and I looked at the time taken for the systolic blood pressure to return to within 80% of the pre-anaphylactic blood pressure. And the mean and median were about the same, and they were somewhere between about 12 and 15 minutes. And the vast majority, I can't remember the exact number, but it was in the realm of about 80 to 90%, returned to within 80% of that blood pressure within about 20 minutes. Now, that's not to undersell that 20 minutes, because that was harrowing for the person looking after that event, but it tended to have a pretty finite endpoint, and the cases that really extended beyond that were the minority. There were some that lasted in excess of an hour, but they were few.
The other important thing is that a lot of the patients that suffer anaphylaxis under anaesthesia, it's completely unpredictable, and I think because the majority of patients having surgery are often young and otherwise well, it would come as an awful shock if anaphylaxis intervened and you're managing a patient that is suddenly so unexpectedly unwell. But we know that the outcomes are incredibly good, particularly for the most severe cases of anaphylaxis, grade 4 anaphylaxis. These are cases where the patient's progressed to being pulseless and has needed chest compressions. Now, normally, in the community, there survival in that situation would be less than 10%. In a hospital, the survival would be about 30%. But in an operating theatre under anaesthesia, the survival is well over 95%. Knowing that the survival is so good, people just have to persist with doing the basic things, giving volume, giving adrenaline, and managing the airway.
So you've treated a patient that's had an anaphylactic reaction. What's the next steps under surgery?
Where you move to from there would really be dependent on the surgery type, the patient that you're looking after, and what's available locally to you. Paul and Peter talked about a study that we did that looked at continuing with surgery and the outcomes, and we found that in the sort of moderately severe group there was no change in outcome if surgery was continued. I think we need to sort of consider what's available. You know, if you're in a regional centre, that may not be the ideal situation, but it certainly, we wouldn't criticise you for continuing with surgery because there is quite good data to suggest that the patient doesn't generally come to harm if that's the case. To further carry on with the treatment though, I would ensure that the patient can be continually managed. I would have a frank discussion with the surgeon as to whether they continue with the operation or postpone it. And then there'd be some discussion about the disposition of the patient. If the patient had a severe reaction, we would recommend that they go to an intensive care unit for observation afterwards. That may well be more difficult in the regional setting than it is for us, but that would certainly be something that would be considered, and hospital transfer is often the end result. The other thing that really needs to be a consideration is facilitating our diagnosis. A tryptase level is looking at the enzyme that mast cell tryptase that's secreted by a degranulated mast cell during an anaphylactic event, and we're able to measure that, and an elevation in the tryptase level is very useful in our diagnosis subsequent to the event. Having an elevated tryptase for us means that the anaphylaxis as the cause of the event is much more likely. The opposite of that is that a negative mast cell tryptase is also very useful for us, and we would consider other diagnoses as well. So that's what I think would be the main points of treatment after the event.
It's interesting in that in anaesthesia we give all of our drugs intravenously, or most of them are given intravenously, so the reaction is usually within minutes, and usually you have a maximal reaction initially. What we don't see, I know in the community with allergens that are ingested, you might see a biphasic reaction. We don't tend to see that after anaesthesia. Nonetheless, people can have symptoms and require ICU care for several hours or days.
Sorry, one other extension of the treatment would be to consider the causative agent. What we don't want to do is re-expose the patient to the allergen. I would recommend that you would carefully analyse what had been given, inclusive of intravenous drugs, intravenous fluids and skin preparations, and avoid the likely allergens. So that may well mean that, you know, we have anecdotally have seen some cases where subsequent to the reaction gelafusine or another allergic fluid is given subsequent, or the patient has re-exposures to chlorhexidine with another subsequent event. So I would sort of carefully consider the likely allergic causes and do everything in my power to avoid them.
Yeah, in that setting, there's a few allergens that we sort of consider to be hidden allergens that you might miss. One of them is gelafusine, because you often don't think of that causing hypotension. You often give it to try and treat hypotension. And the other one's chlorhexidine, and especially chlorhexidine hidden in things like impregnated central lines. And it's not uncommon for patients to have anaphylaxis. Well, most of the central lines inserted at the moment are chlorhexidine coated, and we do see patients going to intensive care unstable with an unknown source of anaphylaxis, and they grumble on for days needing adrenaline because of this chlorhexidine coated central line which is causing the anaphylaxis.
So we believe that we've had an anaphylactic reaction, and sometimes it's not absolutely clear whether you have had an anaphylactic reaction or not. But if you think you have, then we have the Anaesthetic Allergy Clinic at Charles Gairdner Hospital, which we accept referrals to. And we encourage people to refer, even though they might not be absolutely sure whether they have or not had an anaphylactic reaction, because sometimes it's not even absolutely clear after you've even done the testing. But if anybody refers a patient to us, we will usually see them Because if you don't, then they have this spectre of anaphylaxis hanging over them for the rest of their lives. So we like to sort it out. So it's just as important for us to see patients and get a negative test as it is to get a positive test. Okay, so we can clear it up for them. We can say, go home, don't worry about it. This wasn't anaphylaxis. You're not going to come to harm in the future if you have an anaesthetic, which some people carry around for years and years and years because they've never been tested. I mean, we see lots of patients who have had lignocaine allergy for 40 years, and they haven't. Okay, so it's good to rule out anaphylaxis. Now, to be able for us to evaluate a patient, then we need as much information as you can give us. A one-line referral is no good. What we need is a letter describing what happened. We need result of a mast cell tryptase, and hopefully you will have remembered to do that. And we also need a referral form that has been designed by the Australian and New Zealand Anaesthetic Allergy Group, and this is a group of experts around the country who did testing around the country in Australia and New Zealand. And they put together this form that essentially lays out the important things that we need to know. And that can be obtained from www.anzaag.com. And just about everything that you need to do as far as a referral is concerned is described on that website.
The ANZAG website, it's a very useful resource. The background of it is that it was put together, people doing this sort of testing throughout all of Australia and New Zealand, and a lot of effort went into it. The website has very useful documents, not only the referral letter that's there, but also all of the treatment cards, which will go into a lot more detail about treatment than what we spoke about. It also talks about contact details for the nearest centres and various other sort of reference materials. The one thing that we didn't talk about is it's sort of in vogue to have an anaphylaxis box in the hospitals. The contents of what we would recommend is contained on that website, but really the main things in it really are treatment cards, referral letters, and are the appropriate blood tubes for mast cell tryptase levels. So, I would recommend that people from some of the regional centres look at that website because it is a very useful reference.
So once the patient's been referred to you, what's the next step of the process in terms of treatment at the clinic?
Well, the first thing we need to do is gather all the information. So we usually talk to the referring clinician, and I think it's really important to get a first-hand description of what happened, because often what the person referring thinks is important for us to know. Well, it always is important for us to know what they think is important, but there's always other things that we want to ask them about to give us clues about what could have happened. Often, for instance, they wouldn't mention some of the triggers that were given unless specifically asked. So that's always important. So we'll always gather as much information, we'll talk to the patient, find out how they've gone since their procedure, and take a more distant history about previous anaesthetics. But look, at the end of the day, the main diagnostic test that we have is skin testing, and this we do in our clinic. It only takes about half an hour. We try and be a one-stop shop, so particularly rural patients will come down and see us once, and we'll investigate them fully and usually come up with an answer that day. There will be some tests that come back subsequently, some blood tests that we can send, but we try and sort them out in one visit. So we take a detailed history, we do skin testing, and skin testing is very safe. We use about a millionth the dose that they would have got during the anaesthetic, and we either use skin prick or intradermal testing, which is very well tolerated. The risk of a patient having an adverse reaction is extremely low. So we can reassure them that it's very safe to have testing. And look, we usually have an answer within 15 to 20 minutes. And then what we do, a very important part of our job is, once we've found out what they can't have in future, is planning their next anaesthetic and making suggestions for the clinicians that will look after them subsequently. And that includes sometimes when we don't find the cause of the adverse reaction, but we still need to design a safe anaesthetic for them to have in the future.
So what are some frequently asked questions that you receive from doctors?
Well, one of the common ones is whether we can safely give cefazolin, which is a cephalosporin antibiotic, to someone who's penicillin allergic. That's a very difficult question to answer. The science behind that is cefazolin allergy is almost always caused by an allergy to the side chain of cefazolin, which comes off the beta-lactam ring. They are almost always not allergic to the beta-lactam component of the cephalosporin. It's that side chain. Historically, they've mentioned a cross-reactivity rate between penicillins and cephalosporins of about 8 to 10%, and that's something that we think is hugely overestimated. The problem with that is people who are allergic to one drug are more likely to be allergic to another drug. So someone who is penicillin allergic may well also have an allergic reaction to cephalosporins. It's very difficult to say whether that's related to a cross-reactivity from their IgE or two separate allergies. The other thing that makes things more complicated is that medico-legally there still exists a notion out there that we should be using alternative agents in someone that's penicillin allergic. So there's a lot of grey area. In my own personal practice, I would take questions about their penicillin allergy, in particular about the severity of it. And if they had a severe reaction to penicillin, I would use an alternative.
Yeah, well, I consider cefazolin to be a drug that's distinct to all of the other cephalosporins and penicillins. I mean, having said that, there are definitely patients out there that will react to several, and whether that's, like Russell said, if that's cross-reactivity or is that patient just actually allergic to lots of drugs independently with no relationship between the antibodies is a question. Certainly in current practice, most clinicians will give a patient who's had a mild previous reaction to a penicillin, which is usually something like amoxicillin, which has distinct side chains to cefazolin. They will give them cefazolin. It would be very rare that we'd see anyone that would have an adverse reaction.
The surprising thing, I think, is that most of the drugs that patients are allergic to, they haven't been sensitised by previous exposure to a drug. So let's talk about muscle relaxants, for instance. Muscle relaxants, an anaphylaxis very often happens on first exposure. So it's not like a patient has had 4 or 5 anaesthetics before and becomes sensitised to a muscle relaxant and then had a reaction. There are sensitizers in the community that are making us develop antibodies to drugs to which the patient is totally unaware of. So there's a common cough mixture that just about everybody uses when winter comes along that contains Folcodine, which is a cough suppressant. And it has been pretty well established that this drug is responsible for the production of antibodies that are generated by exposure to Folcodine but recognize a part of the molecule of a muscle relaxant. So unwittingly, taking Folcodine, cough suppressants, results in an increased risk of having an anaphylaxis to a muscle relaxant. But there are a lot of other things in the environment too. You can be bitten by a tick and sensitized to the gelatin-containing colloids. Patent blue dye allergy is probably because you've been exposed in the environment to multiple other blue dyes in that family. Chlorhexidine we're exposed to all the time. You know, people use chlorhexidine mouthwashes. They use it as an antiseptic for minor cuts and bruises, and they're probably being sensitized out there in the community. So most of these things that we see anaphylaxis to in the operating theatre are due to community sensitization. Now, Sugammadex, this new wonder drug that reverses steroidal muscle relaxants extremely efficiently, we have seen in the last few years a dramatic increase in the numbers of allergic reactions to Sugammadex. It's a cyclodextrin, all right, which is a very complex sugar that is used in a lot of things that we eat or drink or medicines that are found in the community. Okay, so it's quite possible that we are being sensitized to Sugammadex from what we eat and drink in our normal everyday life. But Russ will tell you a bit more about Sugammadex because I think that's important. I think it's only recently become clear to us that this is quite an allergenic drug, and Russell will know the numbers.
Well, yeah, I mean, just as an extension of what you said there, Peter, for a lot of the general practitioners out there, Folcodine is almost certainly the sensitizer of muscle relaxant allergies, which causes considerable morbidity for our patients. And that is something that clinicians in the rural community can consider, to not give Folcodine, because that would certainly be advantageous from an anaesthetic allergy point of view. There are great publications from Scandinavia that go through a lot of the thinking behind Folcodine, and should you be interested, I'd recommend you read it. Western Australia is in a unique area because our use, at least within Australia, is much higher with Sugamidex than any other area in Australia because of some commercial agreements that were made between the hospital and the supplier. What we've found that Sugamidex is allergic. We're still trying to get a feel of the exact incidence of that rate, and hopefully that will come in the near future. But we're seeing, on average, probably about 4 or 5 allergic reactions per year in Western Australia, and that has probably increased in incidence over the last few years.
I think, the important thing to consider is the alternative to Sugamidex is neostigmine, and the rate of allergic reactions to that is well known, and that's 0. So there really has to be tangible benefits to accept any increased risk.
Betadine allergy, all right, is an allergy to povidone, all right, which is one of the constituents of betadine. It's nothing to do with iodine at all. Radiological contrast media contain iodine, but there are other aspects of allergic reactions to that group of drugs that are much more important, and essentially it's unrelated to the iodine component. I did have a patient once who was told when he left the hospital after he had a relatively minor allergic reaction to radiological contrast media that he mustn't eat anything with iodine in it. And for the next several weeks he spent a large amount of time going around the supermarket looking at every ingredient of everything that he bought at the supermarket. So yeah, iodine allergy does not exist. Okay, radiological contrast media, betadine allergy does exist, but it's nothing to do with the iodine component.
Yeah, but interestingly, the povidone that you mentioned is present in a lot of tablet formulations, and it's present in one of our formulations of intravenous paracetamol. So we have had someone who was allergic to both betadine and paracetamol, even though they could have different formulations of paracetamol.
As an extension of the sort of iodine allergy, another thing that patients often say to us is they're allergic to all drugs containing sulphur. You can't really be allergic to an element. The history behind that is a lot of these reactions came from sulphur-based antibiotics, and those reactions were certainly genuine, but they were reactions to the antibiotic itself rather than the element sulphur. There are numerous drugs that we give that contain sulphur, but there isn't a cross-reactivity between those.
The two drugs that we most commonly get asked about are pericoxib, which is one of the non-steroidal anti-inflammatory drugs for which there is an intravenous preparation for, and is commonly used as one part of our analgesic management for patients. That has a sulphur component, but as far as we know, there's no cross-reactivity between people who have a sulfonamide antibiotic allergy and that drug. So I think it is quite reasonable to suggest that it's quite safe to use pericoxib in people who have got a sulfonamide antibiotic allergy. The other drug is acetazolamide, which is quite often used in eye surgery, and also in people who go mountain climbing to prevent altitude sickness. And I think if somebody's got a sulfonamide antibiotic allergy, it would probably be worth trying your acetazolamide before you set off for the Himalayas.
The majority of patients that come to us haven't actually had an allergic reaction, but they've had a serious concerning reaction, often in dental chair anaesthesia with local anaesthetics. And they definitely did have a reaction. They may have had a reaction to the pain of injection of the local anaesthetic. They may have had a reaction which is a predictable reaction from toxicity from the local anaesthetic, because you actually absorb a lot of local anaesthetic through your gums. But that would be a predictable dose-related reaction. Or even you could have a reaction to something like adrenaline in the reaction. But of course we have to exclude the possibility that they had an allergic reaction, because subsequently the reaction could be a lot worse. While it is possible to have anaphylaxis to a local anaesthetic, we find in the vast majority of cases that hasn't occurred. But it's a worthwhile experience seeing these patients, testing them and reassuring them that that next time they needn't be so worried.
I think this is the reason that a lot of people get labelled, because a dentist will have given either a large dose of local anaesthetic or an adrenaline-containing solution, which has caused a reaction. But they don't. But they say to the patient, I believe that you're probably allergic to the local anaesthetic. All right. So we've now got a labelled patient. Okay. So very, very few of those patients actually, when we test them, do we find that they are truly allergic. Now that's possibly because, or partly due to the fact that most of the local anaesthetics we use now are of the amide group of local anaesthetics, which very, very, very rarely cause anaphylaxis or allergy. There are some local anaesthetics that are used in topical preparations for your sunburn or for the treatment of your hemorrhoids that contain ester local anaesthetics. And those were much more commonly associated with local reactions. You know, any GP out there would know about, you know, the local skin reactions that seem to be allergic when you're using those type of topical local anaesthetic preparations. A lot of those were diagnosed by the dermatologists, and they would use patch testing to test these patients, but they would then be called or told that they were allergic to all canes. All the local anaesthetics have got lignocaine, marcaine, methocaine. Okay, so they'd be labelled as allergic to all the canes. Okay, so these poor unfortunate people would go through all sorts of horrendous procedures without, you know, getting local anaesthetic. You know, women not being able to have an epidural because they're allergic to local anaesthetic. Even more horrifying stories, which I won't go into.
I agree with everything that you guys said about the local anaesthetics. I think it's really important, though, that we sort of respect their allergies to a certain extent. And even though it's highly unlikely that they would be allergic to local anaesthetics, I wouldn't recommend anyone sort of ignore that. I think diagnosis and identification of an appropriate agent from us would be the way forward.
If you had somebody present to your pre-op clinic or just before you were going to give somebody an anaesthetic and they said they were allergic to local anaesthetic, you should take that as on face value and not call it that they are not allergic until they have been tested.
Are there any research areas you've been involved in that you've found quite interesting?
One of the advantages of our clinic in Western Australia is it's the only anaesthetic allergy specific clinic in the state. And we've worked quite extensively to have quite an easy referral process. And that's led to us sort of being pretty confident that we see the vast majority of at least moderate to severe anaphylactic events intraoperatively. So being, you know, having such a sort of an ecosystem of allergy, that's shit. So being able to see all these cases has allowed us to identify some local trends. And one that's recently we've become aware of is that it seemed as if the obese population was overrepresented in terms of muscle relaxant allergy. And that was not only people who had muscle relaxant allergy in general, but specifically people who were having obesity-related surgery. So we endeavoured to sort of audit our obese populations that have come through our clinic. And what we found was the rate of anaphylaxis to muscle relaxants was much higher in someone presenting for obesity surgery, probably in the realm of about 5 to 6 times as likely as the non-obese person. And the other thing that we did was we looked at the BMIs of people who were found to be allergic to muscle relaxants and compared them to people who are allergic to kefazole, and there was a very large difference, and that difference got larger the more obese the patient became. The next question is, I guess, that follows is, you know, why is an obese population more likely to be allergic to muscle relaxants? We don't really know the exact answer. In my eyes, there's probably 2 potential answers. One is that they're exposed to the sensitising agent for muscle relaxants more commonly than the non-obese, and in particular Fulcadine. And the other potential explanation would be that being obese modifies your immune system and changes your allergic processes. So historically, there hasn't been a great deal of research and publications relating to anaesthetic allergy. We've been very fortunate to be involved in some of that in the last decade. But what we've noticed is that there is a lot more information coming out. There's a really good sort of specialist series that's coming out in the British Journal of Anaesthesia that we've been lucky enough to be involved with, that I'd recommend people look into. And we really hope we can just continue the ball rolling and to educate people about what we see, and to try and facilitate people's safety in the future.
Thank you so much. It's been a pleasure chatting with you. And is there any other further resources that people can go to if they'd like to seek more information?
Just Google perioperative anaphylaxis and you'll find a lot of information. But really the ANZAG website is the place to go to. If anybody's got any questions, any concerns, just give us a call and we'll be very happy to answer them.